I thought of discussing aspirin because there were some new studies about primary prevention. I'm not talking about the secondary prevention. It's only about the primary prevention. I'll be talking about using aspirin in normal healthy subjects and diabetic patients without cardiovascular disease. If you go to the NICE guideline, it will ask you to do Q risk before you start on aspirin. So the Q risk, when you do Q risk, if you even for you to do for yourself, use the latest 2018 version, not the 2017 version. The 2018 version is updated one, which include whether you have got migraine, and then whether you are having any mental illness, and whether you are on atypical antipsychotic medications and steroids. So these are considered as risk factors in the new one. And if you put your figures, this is how you will get your risk assessment done. And it will tell you what's your 10-year risk. If it is more than 10, it's significant, and it will give you your Q risk 3 healthy heart age as well. Till about 2016, primary prevention was thought to be beneficial, but there was an unclear risk to benefit ratio, and it was thought that there's about 12% risk reduction by using long-term aspirin, but everyone knew there is a risk of major bleeding. However, if it's a secondary prevention, it has proven benefits, though there is a risk of bleeding. So we are not going to discuss the secondary prevention here. If you take aspirin, aspirin was manufactured, one of the very oldest drugs, 1899. It's quite controversial in primary prevention. In secondary prevention, benefits of aspirin have outweighed the risk of bleeding. And in diabetes has been associated with an increased risk of first and recurrent thrombotic events, making aspirin a potential option. Sometime back, if you go back to about 2005 or before, every diabetic patient was asked to be put on aspirin. Now we don't do that. If you look at the meta-analysis, this was published in 2000, and this is I think 2009. Yeah, 2009. Most of the data shows a beneficial effect for primary prevention, except the stroke death. And if you see the physician's health study, nearly about 11,000 patients in each group. There were 239 heart attacks, and then 139 in the aspirin group. So 44% reduction in MI with aspirin use. So to clarify things, there were large studies done. So we have got the data results of ARRIVE study, ASCENT study, and the Aspirin study. So I will discuss these three and then finally tell you what the NICE says about using aspirin in healthy adults and diabetic patients. If you talk about risk factors for primary prevention of cardiovascular disease, I think one single factor, if you're talking about, is smoking prevention. But other risk factors are old age, male sex, race, ethnicity, abnormal blood lipids, high blood pressure, diabetes, and smoking. So subclinical diseases like type 2 diabetes, subclinical type 2 diabetes, metabolic syndrome, or left ventricular hypertrophy, carotid artery stenosis, and peripheral vascular disease and microalbuminuria all are associated with increased risk of cardiovascular disease. These are guidelines issued mostly by the Americans in 2016. this tells you adults less than 50, aspirin as primary prevention not recommended, and adults between 50 to 90 with a cardiovascular risk of more than 10% over the next 10 years, initiate low dose aspirin. That's the recommendation. That was 2016. It's a grade B recommendation. And then adults between 60 to 90, it should be an individual decision. Not at risk for bleeding, have more than 10 years of life expectancy, and willing to take daily for 10 years is the sort of criteria. Above 70, it's not recommended. You would see, if you do a take, you would see how many elderly people are having aspirin without any indication, just primary prevention. So aspirin, what it does is, the peak plasma concentrations are reached within about 30 to 40 minutes in an uncoated aspirin. If it is coated one, 3 to 4 hours. Half-life is about 15 to 20 minutes. However, the inhibition of platelet COX-1 activity is about 7 to 10 days. So that's the most important thing. So other biological effects, like it does not impact on blood pressure because it has minimal COX-2 and PGI2 activity. Increased risk of GI bleed because of permanent COX-2 inactivation. And aspirin resistance is rare. So I'll briefly discuss about 3 studies. The one is ARRIVE study, which was published in 2016. They had 12,546 patients who were all more than 60 years old with no history of known cardiovascular disease at moderate risk of cardiovascular risk, like 10 to 20% 10-year risk. So they gave aspirin 100 milligrams to a group, and the placebo was just placebo tablets. Follow-up for 5 years. The aspirin patients had lower cardiovascular death compared to the placebo, but though this bar looks bigger, if you look at the actual percentage, is 4.3% here and 4.45% for the placebo group. So it's in absolute numbers, it's not really big. If you see the gastrointestinal bleeding, it's again higher for aspirin and less for placebo. If you see the hazard ratio, it was 2.11. That's the most important thing here. So if you see the benefit, it's not that significant compared to the hazard of gastrointestinal bleeding. So both had similar overall adverse effects, other overall adverse effects. And the final conclusion was the role of aspirin in primary prevention among patients at moderate risk could not be addressed in this study because it's the moderate risk patients because it was underpowered. However, it showed reduction in cardiovascular death, but at a higher risk of developing gastrointestinal bleeding. And if you see the primary prevention trials in diabetes patients, this is the a meta-analysis in 2019. If you see, most trials showed some benefit, except few showing no benefit or harm. So this study was published in 2018. This addresses the issue of diabetes and aspirin. They also included omega-3 fatty acids. So they had 15,480 patients Patients were more than 65, adults with diabetes, but no evidence of cardiovascular disease. They gave, one arm was 100 milligrams of aspirin daily with 1 gram of omega-3. The other arm had 100 milligrams of aspirin and placebo. And then the other arm had placebo plus 1 gram of omega-3, and the other had placebo plus placebo. So the primary outcome was first serious cardiovascular event like MI, stroke or TIA, or death from any vascular cause, excluding ICH. And safety outcome was first major bleeding event, and then secondary outcome was GI tract cancer. GI tract cancer was studied here because there were some evidence to say colorectal cancer was less with long-term aspirin. So in summary, over a mean follow-up of 7.4 years, less serious vascular events were seen, but more major bleeding occurred in the aspirin group compared with placebo group. So if you see the aspirin group, the cardiovascular event was 8.5%, and non-aspirin group, placebo group, was 9.6%. It was a 12% reduction in events. However, the major bleeding events were 4.1% in aspirin group and 3.2% in placebo, therefore a 29% increase in risk of major bleeding. So whether it's worth giving aspirin.
That 12% reduction is only a relative risk reduction.
Yes, relative risk reduction. Yes. So yeah, if you look at the absolute risk reduction, it's only 1%. So in diabetes patients, the platelet activity is abnormal. So diabetes patients have hyperactive platelets with enhanced adhesion, activation, and aggregation. Obesity, dyslipidemia, kidney disease, and systemic inflammation are known to contribute to platelet abnormalities. More frequent expression of glycoprotein 2B, 3A, and upregulated P2Y12, and shorter platelet lifespan and increased turnover. So everything leads to accelerated thromboembolism. Recommendations for diabetic patients. American Diabetic Association said consider aspirin for type 1 or type 2 diabetes with 10-year CVD risk of more than 10%. Not recommended for adults with type 2 at lower risk, that means less than 5%, or the patient is less than 50. In type 1 and type 2 diabetes who are pregnant, to prevent preeclampsia, you should prescribe aspirin. That was the ADA recommendation. The American College of Cardiology, American Heart Association, and ADA said it's reasonable to prescribe if the risk is more than 10. American Association for Study of Diabetes, they flatly said antiplatelet therapy is not recommended for people with diabetes who do not have cardiovascular disease. So this is another interesting trial. I'll briefly tell you. This I put this slide because this study included clopidogrel, aspirin, and omeprazole, and then clopidogrel and aspirin. So this study showed, I'll just be brief, using omeprazole with clopidogrel does not increase any cardiovascular events. So there doesn't seem to be an interaction between omeprazole and clopidogrel. Right. So what about regular use of aspirin and cancer? Again, this is the JAMA publication in 2016, a meta-analysis. GI cancers seem to be reduced with long-term aspirin use. However, total cancer seem to have not changed. This study, the Aspirin, this was the latest to be published in September this year, addressed this issue. The double-blind randomized primary prevention study in the elderly, they included patients in United States and Australia. There were closer to 20,000 patients, all above 65, free of dementia, cardiovascular disease, or any physical disability. So they gave aspirin versus placebo. It was to finish in January 2019, but they terminated the study prematurely and published in September 2018. So they looked at primary efficacy endpoint was slightly different to all the other studies. This study tells you disability-free survival. So in an elderly patient, that's the most important thing. You should survive without disabilities. So they looked at the disability-free survival with primary endpoints comprising of all-cause mortality, including dementia or persistent physical disability. And then also looked at primary safety endpoints as major hemorrhagic events, including hemorrhagic strokes. So briefly, I'll give you the summary of the results. So people using aspirin had 21.5% in the endpoint, like death, dementia, persistent physical disability, and placebo was 21.2, and the p-value was 0.75, so there's no significant difference at all between the two groups. So this is one of the largest studies. So if you look at the hemorrhage, its major hemorrhage was 8.6% with, these are absolute numbers, 8.6% with aspirin and 6.2% with placebo. And then cardiovascular events slightly lower for aspirin, but it's not significant in this study. So if you look at other findings, deaths related to cancer was slightly more with aspirin. This was an unexpected finding. I'll show you in the next slide. If you see, the number of deaths from cancer with aspirin was 295. A number of deaths from in placebo group was 227. I don't know whether the duration of the study is enough for us to come to conclusions about cancer and aspirin. However, there's some trend towards non-benefit even with regard to cancer. All the other, like death due to major hemorrhage was equal in aspirin and placebo, and cumulative incidence was nearly same for aspirin and placebo. So now NICE has come out with a recommendation after this study. NICE says primary prevention of CVD age 16 years onwards. Do not routinely prescribe antiplatelet treatment for primary prevention of cardiovascular disease. Consider prescribing aspirin in people with high risk of stroke or myocardial infarction. In deciding whether to treat or not treat with aspirin, consider the following. Aspirin is not licensed for the primary prevention of CVD. People may be able to reduce their CVD risk through other means such as stopping smoking or starting statins. There is limited evidence of benefit even in people with multiple risk factors, and there is a risk of harm. So that's the latest NICE guideline. So with that, I conclude here. I think